Good evening, respected doctors. Myself, Dr. Nitin Kapure, a senior medical advisor from Alkem, a qualified doctor with a post-graduation in MD Pharmacology. On behalf of Alkem, it is my great pleasure to welcome you on this international speaker program. As you know, epilepsy is one of the most common serious neurological disorder affecting more than 70 million people worldwide. And despite the addition of nearly 20 new anti-epileptic drugs in last 2 to 3 decades, still more than 30% of the patient fail to achieve prolonged seizure freedom. And further, many patients suffer from the adverse effect of anti-epileptic drugs, and which is responsible for the poor adherence as well as the discontinuation of drug. So therefore, the need to discover new AD with an improved efficacy and better tolerability profile has always been there. Brivaracetam is a new anti-epileptic drug approved by the important regulatory bodies, including India. We as Alkem also launched this product recently and want to disseminate the most up-to-date scientific information regarding this with you for the better patient management. So for this, we have an eminent international speaker, Dr. Martin Brodie, with us, who is a clinical and research director, epilepsy unit from the University of Glasgow, and the doctor will talk about the disease unmet need, a novel treatment option, as well as the Brivaracetam, how the Brivaracetam can fulfill this disease area, right? And he will also try to address your queries. And so more of the introduction will be taken by our moderator, Dr. Tapas Kumar Banerjee. I request, thank you, support. So I'll introduce the moderator, Dr. Tapas Kumar Banerjee. Sir, Dr. Tapas Banerjee has a qualification of MBBS, MD, FRCP from London as well as the Edinburgh. And sir is a fellow in Arn as well as the IAN. Sir is a medical director for a National Neuroscience Center, Kolkata. Sir is also consultant neurologist from Peerless Hospital and BK Roy Research Center, AMRI Hospital, Kolkata. Sir awarded with the Mother Teresa Ratna for rendering the unending selfless service to the mankind. Award given by the Award Committee of All India Minority as well as the Weaker Section Council. Sir also awarded with the Mother Teresa International Award for outstanding achievement and contribution as a physician. This award is given by again Award Committee of All India Minorities as well as the Weaker Section Council. Sir has a several contribution of chapters in textbook articles in various national as well as the international journals. Till date, sir has a 66 major publication in leading international journal and co-chaired in the Sevier International Conference. So with this, I am handing over session to Tapas sir. Over to you, sir.
Okay, good afternoon, Professor Brodie and my friends. Today we have a very interesting program. We are actually having a lecture by Professor Brodie on this very new molecule, Brivaracetam, and then we'll have a panel discussion. We have esteemed panelists from across the country. First of all, may I introduce Professor Brodie formally? Because, can you enlarge the slide, please? Thank you. Professor Martin Brodie doesn't really need any introduction among the people in the field of epilepsy in this country and in fact across the world. But as it is customary, I'm going to introduce him. He's a clinical and research director, Epilepsy Unit, University of Glasgow, President, International Bureau for Epilepsy. Dr. Brodie has been involved in epilepsy drug development for more than 30 years and was principal investigator on numerous trials that brought new therapies to market. He was an innovator of novel trial designs and is arguably the most recognized speaker on new anti-seizure medications in the world. He is a European Epileptology Awardee, Epilepsy Lifetime Service Awardee, Epilepsy Lifetime Awardee, published more than 500 articles. The flow of the meeting will be like this. We'll first have the lecture by Professor Brodie, and this will be followed by a question-answer session where we'll have the members of our esteemed panelists. And I think if all our panelists have joined, am I going to introduce all of them right away? Do you think everybody has joined? If not, then...
yes, sir, everybody has joined, sir, except Dr. Gentleman.
Okay, in that case, we'll start with Professor Brodie's lecture. May I invite Professor Martin Brodie to deliver his lecture?
There we go. Now you can see why I have a juggling person to introduce me, as we never know quite in this COVID world what's going to go wrong. But hopefully not for long. I'm going to, for the next 40 minutes or so, talk about the place of Brivaracetam in the context of uncontrolled epilepsy. And so the first part of my presentation is about uncontrolled epilepsy, and then we'll go and talk about this new compound. These are my declarations of interest. Over the years, and there have been many of them, I've studied all the drugs in the bubble here. And then one at the top, as you can see, is Brivaracetam. So really that's the latest drug that has been widely licensed across the world. And we still have others down there. Cenobamate will come, cannabidiol a little later, maybe in a different formulation. But all the others we now know very well. Over the years, I've collected data on all the patients that have attended my clinic. Most of them initially newly diagnosed, or many of them, and this has given me the opportunity to have a flavour of how epilepsy behaves. So this study is a study of 1,098 adolescent and adult patients starting on their first anti-seizure drug between 1982 and 2005, and followed up for at least 2 years. And what I used this data set for was to look at the patterns of drug response in the individual patients. So we have 4 patterns. Pattern A, seizure-free immediately or within 6 months of starting treatment and continuing through follow-up. So these have done really well. More than a third really do very well. Some of whom can come off medication, of course. Another fifth or so, after tinkering a little bit with the drugs and making sure that the patient takes them, they become seizure-free too. So that's about 60%. And then we have a group that comes and goes, that at any one point they can be seizure-free, or at any one point they can have refractory epilepsy. And they're a tricky population of patients to follow up. The last group are not so tricky, but not so easy. And that's about 25% of patients who never become fully controlled with the drugs that we have, even though we can improve them a little, but they never become seizure-free. So you can see that we can do well in a lot of people, but we don't do well in quite a lot as well. And this is the challenge for any new medication. So 2 populations, really. We have those that become seizure-free and stay seizure-free, those who have refractory epilepsy right from the beginning. And in between, there's a few patients, 15% or so, who relapse and remit. And it's useful to get a flavour from each patient about which category they are going to fall into, so that you can choose the best treatment and give the right information to the patient and their families. When we first started out collecting data from our patients, we aimed to publish what we could. And I'm always telling my young doctors, you should publish everything that you can and everything you see, and then you know what you're trying to do. I didn't realize at the time that this small study that we published would be published in the New England Journal of Medicine and would be the most cited anti-seizure drug epilepsy paper in the literature. And I'll show you why, because it gave us the pattern which is followed up now over years of what happens to individual patients that I touched upon earlier. So I'm going to show you the data from the first study, which is a small study. I'll show you the numbers in a minute. And I'm going to show you a comparison with what we've done laterally, which has just recently been published in JAMA Neurology. And this is of over more than 8,000 patients who are in the database. And this continues to expand. The latest analysis cutoff was in October 2016, which I'm going to show you, and we did the analysis 2 or 3 years later. So there was 1,795 eligible patients included, all followed up for at least 2 years, and they had to be seizure-free for that time. Now, I'll give you a second to look at this, because this is the seizure-free model at the last follow-up visit from the first group of patients, 470 patients that were published in the New England Journal, and the second group of patients. And we did some analyses in between, but this was the one in JAMA Neurology in 2018. And this was 1,795 patients, so a number of years later. Now, if I switched these figures, you wouldn't notice the difference, would you? This is seizure-free in the first regimen is blue. Seizure-free in the second is, you can see, a sort of orangey color. And then we have fewer, but some seizure-free. And uncontrolled of the population, 36% in 2000. And 20 years later, 36%. So that tells you that our anti-seizure drugs are not anti-epileptic. And that's why we call them anti-seizure drugs, because we treat the seizures with these medications. We don't treat the causes of the seizures. So when we actually compare the numbers, as I said to you at the end, we got 64% seizure-free in both cohorts. But in the second analysis, 1982 to 2014, we had more patients controlled on polytherapy. So we are seeing some patients drop off, but with the newer drugs that we have, we are getting more patients seizure-free. So they're not doing nothing. They are improving the outcome. But we're still a long way from making all our epilepsy patients seizure-free, and there's at least a third who don't become well-controlled. And you could say, well, you're giving the same drugs, so what difference is it going to make? If you're giving the same drugs, you're not going to get any better outcome. Well, we're not giving the same drugs. I don't use carbamazepine at all now. I haven't done in our service for more than 15 years. You can see the green has disappeared. I still use valproate, of course, particularly for the primary generalized epilepsies, and we use a lot of lamotrigine. Increasingly, we use levetiracetam and lacosamide. So over that period of analysis of 30 years, we have changed the drugs. So it's not the drugs that's the issue, it's the epilepsy that's the issue, that you're not controlling with the medications that we have. So this is the cumulative probability of seizure freedom in the first sort of 10 years or so. We've got 142 patients with newly diagnosed epilepsy. And then if we take it on to 2001, we get a very similar pattern, probability of seizure freedom. And if I told you that when we went to the present day, you see exactly the same thing. So if that doesn't convince you that the overall outcome hasn't changed with the newer anti-seizure drugs, then nothing will. It's absolutely spot on and perfect. But that doesn't mean to say that you're not going to get some of these people seizure-free. About 50% don't control on their first drug, as I mentioned to you. About 11%, and 50% do, of course, about 11% will control on the second drug or second schedule, about 4% on the third. And then you can see, even as we go up to the seventh and more schedules, you're still getting some people long-term seizure-free. So there is a reason to continue and to try different medications. So we're not saying that, as I said, that when you get to the sixth or seventh, we get few people seizure-free. If you look at the total cohort, you're talking about 1%, 0.5%. But if you're looking at the patients who actually get a fourth, fifth, or sixth schedule, it's well over 10%. Because quite often you don't go to those numbers, or the patients say, well, I'm okay, it's a small, I'm only having a few seizures, or they're fed up with the doctor and they don't want to change medications, or they can't afford more medications. So there's still opportunity for getting people seizure-free, even up to the fifth, sixth, or seventh schedule, if you tinker with the medication. And that's for another day, another lecture. So how do we do it? And I'm going to focus particularly on the difficult to control patients during the remainder of this lecture. How do we use the medication as best we can? Well, it makes sense to use drugs together that have different mechanisms of action, that work differently. It's a guess, but it's a better guess than using drugs that have the same, using just sodium channel blockers with other sodium channel blockers. Nevertheless, sodium channel blockers which affect the slow inactivated state of the sodium channel actually do work and can work with those that affect the fast inactivation state, although the side effects do seem to be similar and there is issues with tolerability. But from the efficacy point of view, you can actually use these together. So we have calcium channel blockers, and we particularly pregabalin, which is, I think, probably a better anti-seizure drug than gabapentin, and of course ethosuximide for the children with absence. We have GABAergic drugs, including phenobarbital, and I still use phenobarbital, and I lecture about phenobarbital. I use clobazam. I like clobazam as an add-on drug. I don't use clonazepam much because it's not as well tolerated. And of course, there's little use these days of vigabatrin and tiagabine. But there's quite a lot of use of the drugs that have more than one pharmacological target, and particularly for refractory epilepsy, where you don't know what the target is. So if you use a drug such as topanimate or zonisamide or valproate, which affects many of the pharmacological targets, arguably you're going to get a better chance of seizure freedom, although proving this is not so easy. And most recently, we've had, I mentioned cenobamate and cannabidiol, of course perampanel, which is selective AMPA receptor antagonist. It is an effective drug, but it's a tricky drug to use and has quite a number of side effects. And here at the top there, we have levetiracetam and brivaracetam. They do work roughly on the same site, but they are different. They're different pharmacologically, sufficiently different pharmacologically to not be able to switch one from another and expect to get a better outcome. So I'm going to later in the lecture show you a little bit about how brivaracetam does what it does. And the other thing about brivaracetam that differs from levetiracetam is it is better tolerated. And it doesn't, to the same extent, causes anxiety, depression, psychosis, impulsiveness, hostility, and aggression, which a number of these drugs do, and particularly in the difficult-to-control epilepsies. So from that perspective, I think there is a difference, although, again, it's an overlapping difference. So over the years, we have a number of publications suggesting useful combinations. The only one that I think is synergistic is valproate lamotrigine, which we published many years ago in 1997. But many of these, or I should say most of these publications have been from our own centre. And where it says levetiracetam, you can substitute brivaracetam because the drug hasn't had the time to establish itself in terms of combination. But you can see we've got levetiracetam in a number of settings, and you can put brivaracetam there. So overall, in the difficult-to-control epilepsies, you can get people controlled on 2, 3, and 4 drugs. And you can see in my publication here, we have 64 schedules of patients who are long-term seizure-free on 2 drugs. We have 57 schedules on 3 drugs, and just 6 schedules on 4 drugs. So 2 if you can, 3 if you must, but never 4. And these are patients that are seizure-free for at least a year. And again, if you look at the combinations that are successful in our clinic, valproate lamotrigine is number 1 because we discovered that combination, and so we used a lot of it, and we've published a lot of cases, and other people do too. So you have others there, including phenobarbital and phenytoin, not many, but a few, and they have different mechanisms of action, as I've said. And you have levetiracetam in a number of places there, and again, you can substitute brivaracetam in that setting. So here are the six, the seizure freedom and triple therapy. And again, you've got three of these that have levetiracetam. So again, brivaracetam is a particularly good drug, as is levetiracetam, for combination therapy in difficult to control epilepsy. And I know that now the drug is available for use as monotherapy, and it's a useful drug, as is levetiracetam, as a monotherapy. So, if the patient tolerates the first or second drug well, with a useful response but is not seizure-free, combination therapy should be considered, particularly if there's a lot of seizures around, if it's a high pre-treatment seizure density, and demonstrable underlying pathology helps, such as mesial temporal sclerosis, cortical dysplasia, etc. And so when you're in that setting with lots of seizures and you've got a cause for them and you're on high doses of medication and the patient's not seizure-free, you know that this is going to be difficult epilepsy to control, and you may never get the epilepsy seizure-free. And this has to be discussed as early as you suspect is the case. Otherwise, the patient will lose confidence in your advice thereafter. The other issue is drug burden. So the higher the doses, the less likely will polytherapy be tolerated and therefore effective. But drug burden is a function of the dose and not the number of drugs. So you can use 3 drugs at a lowish dose and get people seizure-free, and you can have the same patient on 1 drug at high dose who's not seizure-free and is having side effects. So you have to learn to use combination therapy as carefully as you can, and then, as I've shown you, you will get people seizure-free with 2 or 3 anti-seizure drugs. So to combine, you start with 1 drug, of course, and then you try another with different mechanisms of action. Sometimes you switch, and again, I'll answer questions on that if they come up. Avoid combining similar modes of action and take your time. Once you know that you're going to have difficult to control epilepsy, you don't want the patient to have too many side effects or they lose confidence again. And be prepared to reduce the dose or even stop the original drug. And you tinker around if the doses are poor in relation to any side effects. So if you're pushing the drug up and the patient hits side effects and they're not seizure-free, this drug is not going to be the best thing for that patient. And as I've shown you, you can use 3 drugs in modest dosing and get a good outcome. Not hugely often, but you can do it. And freedom is the goal for all patients. So for the next 10, 15 minutes or so, I just want to now, having talked about the overall use of anti-seizure drugs in this setting, is to give you a flavour of my thinking of brivaracetam. And we have done some work with it, some studies, and I'm going to show you some of our data as well. And this was licensed for focal epilepsy with or without generalized tonic-clonic seizures in 2016. It does also work for generalized seizures too, for genetic generalized seizures. And we maybe talk about that. I've got a little bit of data on that. It acts as a ligand to SV2A with an affinity that's 20-fold greater than levetiracetam. So it doesn't do exactly what levetiracetam does, but it does, to some extent, do the same thing. And you can argue how much that matters. It's an easy drug to use, rapidly absorbed with kinetics unaffected by food. First order pharmacokinetics, which means if you have 50 milligrams, that gives you plasma levels twice as high as 25, etc., etc. So predictable. It's metabolized mainly in the liver, and elimination half-life is shortish, so it is a twice daily dosing drug, and no problems with the kidneys. And the pharmacokinetics are similar in children and adults, which is useful. And so it's suitable for twice daily dosing in both populations. Side effects are really quite mild: headache, somnolence, dizziness, fatigue, nausea. That's arguably what we get with everything we use. Psychiatric disorders too, as we said earlier, are very common. And here we're talking about less than 3% for Brivaracetam, which is much less than with levetiracetam. When we first started using levetiracetam, we didn't look for this and we didn't see it. But now most of us see at least 20% of patients who have some sort of psychiatric related side effect, particularly with high doses of levetiracetam. This is, with Brivaracetam, this is much less, and this is one of its greatest advantages over levetiracetam. So the psychiatric disorders, however, are there, and particularly in patients who already have them before they started treatment and before they have their epilepsy. And as you know, that can be at least 20% and often more. And for refractory epilepsy, as much as 50%. So we're talking about irritability, agitation, anxiety, insomnia, aggression, which we all know about, and depression. So it does occur, and you have to look for it, even though it doesn't occur to the same extent as levetiracetam does. There are a number of published studies now. There's 6 studies in nearly 2,500 patients, randomized placebo-controlled trials to get the license for add-on treatment. And there is also studies in monotherapy in newly diagnosed epilepsy. And the doses are variable. Mostly we can get away with 100 milligrams or less, sometimes a little bit more, but in the main we don't need high doses. And Brivaracetam is not effective in patients already receiving levetiracetam. You can switch, and I'll show you that in situations where we've done, but you can't combine. It doesn't help, and that's a problem. So there are a number of monotherapy trials which support its use in newly diagnosed epilepsy, which is what you would expect. And as I said, it also works for primary generalized seizure disorders as well as focal epilepsy disorders. So the data are there. And as I said to you before, it's really pretty easy to use. And so you really shouldn't have difficulty getting the best out of it. For Brivaracetam here, there are a lot of different dosage formulations. So you have lots of options that you can see there. And there's an injection solution for babies or intravenous infusion. And of course, it also can be used for status epilepticus, the same as levetiracetam can, although there are no comparisons. So it's useful having lots and lots of formulations so you can tinker around and get the dose right. This is some data of mine that I'm going to give you a flavour of how we use it and how well it does in the setting that I'm trying to persuade you to consider prescribing it. This was an audit. We do audits with all new drugs in newly diagnosed epilepsy over the years. And this is patients 16 years or over with difficult to control epilepsy. 12-week baseline, and then we start the Brivaracetam. And we were aiming for a target of 100 milligrams twice daily. And seizure freedom for 6 months is one of the major outcomes that we do with all our audits, and greater than 50% seizure reduction or less than 50% seizure reduction in patients who continue to take it are the other endpoints. And withdrawal due to lack of efficacy or poor tolerability is the last. And we've done this with every new anti-seizure drug right back to lamotrigine 20 plus years ago. In this study we've just published this year, there's a total of 108 patients who reached an endpoint. 88 had focal seizures and 20 had genetic generalized epilepsies. And as I said, it does work for genetic generalized epilepsy, although it's not licensed for it. But it does do the job, or it can do the job. So this is the Brivaracetam dose in the 4 groups: seizure-free, greater than 50% seizure reduction, less than 50% reduction, and withdrawal due to lack of efficacy or side effects. And you can see in the seizure-free patients, 23% roughly. The patients who do well, in the main, are under 100 milligrams a day, although you can see it does go up to 200 milligrams, as I said. And with the patients who have 50% or more or less seizure reduction, the doses tend to be higher because you push them because the patient's not seizure-free. And similarly with the withdrawal, many of the patients who withdrew either because of lack of efficacy or usually because of poor tolerability did so at low doses below 100 milligrams. So you know pretty early on that that's the case. This is exactly as what we see with all the other audits that we've done. We get the same pattern and almost entirely the same numbers. So the treatment was withdrawn in 34%, a third of patients, usually from poor tolerability, and also lack of efficacy and sometimes both. Sedation and psychiatric side effects were the most common reasons for withdrawal. And, response to treatment, 21.3% of patients remain seizure-free for 6 months. And as I said, this is a similar number that we've had with our other audits. And the median Brivaracetam dose was 50 milligrams twice daily, although it varied from low of 25 to 200 milligrams daily. And this is what one would expect with any new agent. Seizure-free on Brivaracetam monotherapy in 12 patients, because we do try and take away the other drug or drugs if we can, if the patient's doing well. And we have generalized tonic-clonic seizures, absence, myoclonic jerks, completely controlled in 4 patients with JME, with juvenile myoclonic epilepsy. Levetiracetam was previously prescribed in 53% of these patients who had discontinued due to lack of efficacy, side effects, or both. Adjunctive Brivaracetam benefited more than half of these patients. So this is a different drug from Levetiracetam, although not necessarily hugely different. So I'm going to now give you a couple of cases to give you a flavour of how to use it, where the drug has been beneficial. The first one was a 22-year-old lady who presented in 2014 with an 18-month history of episodes of reduced consciousness and eyelid flickering lasting less than 60 seconds, documenting around 6 seizures per month. Otherwise, she was generally healthy and no medication. There was a history of epilepsy in the family in terms of uncles and a cousin. The interictal EEG was okay, but photic stimulation caused eye flickering at 3 per second spike and wave. She was started on Levetiracetam, not surprisingly, and this was increased to 500 milligrams twice daily, and then 1,000 milligrams twice daily. It didn't make her seizure-free, and she started to become irritable and have mood swings, which is very common, as you know, with Levetiracetam. At that time, she was also counselled by epilepsy nurse regarding potential pregnancy issues, because despite all this, she was considering having a baby, and this was not helping with having these mood swings and side effects. So in 2015, we removed the Levetiracetam and substituted lamotrigine. The irritability and mood swings settled, as you might expect, but the eyelid myoclonus continued because lamotrigine is not very good for eyelid myoclonus. Topiramate, not that great either, but that was added in, and she had fewer seizures on lamotrigine and topiramate, decent dose of topiramate. But in 2017, there was still occasional absence and eyelid myoclonus, and Brivaracetam it was introduced. It increased slowly to 100 milligrams twice daily, and she's now seizure-free on the 3 drugs and studying beauty therapy at college. So Levetiracetam at a high dose caused a problem. Brivaracetam was well tolerated and effective and didn't. The next case is a 65-year-old man who suffered right parietal infarct in 2007. In August 2015, he was admitted to hospital with a 2-minute episode of reduced awareness, confusion, and jerking of the right arm, obviously a focal seizure. MRI of brain confirmed an old right parietal infarct, generalized atrophy, and deep white matter ischemia. He was started on Levetiracetam and was also at the time taking amlodipine, bendroflumethiazide, and fluoxetine. He had further 2 seizures at a party in 2017. The Levetiracetam dose was increased, and he became, as many patients on Levetiracetam do, bad-tempered, and he wasn't prepared to put up with it. So we switched him over to valproate chrono, which seemed like a reasonable choice. He had further generalized tonic-clonic seizure in July 2017. So we added in a little lamotrigine to have the combination of lamotrigine and valproate, which I mentioned earlier as being very effective. But they didn't really work, and he was then on quite a lot of valproate for an older chap and lamotrigine as well. He was seizure-free for 4 months until he presented again in 2018 with a cluster of secondary generalized seizures. And I usually find that the patients who have post-stroke epilepsy, when the seizures start, they do get worse and they do get difficult to control. Brivaracetam was introduced and titrated upwards to 50 milligrams twice daily. This improved things, but didn't make him entirely seizure-free. And so we increased the Brivaracetam dose to 100 milligrams twice daily over the next few months. And now he's seizure-free on valproate, lamotrigine, and Brivaracetam without any side effects. And you might say to me, why do you leave him on 3 drugs at decent doses? Well, he's seizure-free and he's got no complaints. And if I take something away, the seizures might come back and I might not be able to get them controlled again. So if it ain't broken, I don't fix it. So to conclude, one of the things that you can have a long lecture about is, I've told you how I think about combining drugs to make people seizure-free. How do we prevent people with refractory epilepsy from receiving treatment with too many drugs? This is often a difficulty. And this must be considered, because if you have 2 seizures a month, you have 2 bad days. If you have side effects, you have 30 bad days. So quality of life measurements do correlate with seizure frequency. So the fewer seizures you have don't reduce the quality of life. If you take them down from 6 to 4, that doesn't make a difference. The only difference you get is with none. So you have to make people seizure-free in order that the quality of life is improved. And just bringing them down and making them less severe arguably doesn't do that when you measure it, not when you measure it. At the same time, if you have a patient seizure-free with lots of side effects, then you're going to have poor quality of life as well. So you need to keep the side effects down as much as you possibly can, and that will improve quality of life. This is a quotation from someone I'm very fond of, and this is Paracelsus. He was a pretty clever guy, and he said, "Poison is in everything, and no thing is without poison. The dosage makes it either a poison or a remedy." And that's the message really for treating epilepsy, particularly for treating difficult to control epilepsy. Don't poison the patient, because they won't thank you, and arguably they probably won't be seizure-free either. So for all epilepsy patients, we have to consider side effects. We have to talk about work and sleep, mood and well-being, and if you're feeling enthusiastic, sexual function. If the patient doesn't tell you, you probably should ask. And we should take a holistic approach using a wide range of anti-seizure drugs and making sure that you don't cause side effects while you're trying to make people seizure-free. And you need to ask about it, and the patient needs to tell you about it, and the family needs to tell you about it. So you need to have a good relationship with your patients and your patient's family. The major message from a pharmacologist, of course, is that a mechanistic approach to the pharmacological management of each epilepsy syndrome will optimize the chance of perfect seizure control and help more patients achieve safer and more fulfilled lives. And for many, a palliative strategy will be necessary for patients with truly refractory epilepsy. Thank you very much.
Thank you, Professor Brodie, for an extremely informative lecture and for your words of wisdom. I think we will now go to our panel discussion, and then there will be question answers there. So if I can introduce the members of our panel. Can you show me the slides? So we have a panel discussion now. The first member is Dr. Atmaram Bansal. Dr. Bansal is MBBS MD DM. He's Associate Director and Senior Consultant Neurology and Epilepsy at Medanta, the Medicity, Gurgaon. He had managed over 5,000 cases of epilepsy of various types, and he has a number of publications, book chapters, paper presentations in national and international journals. He's on the editorial board of various journals and in the books of epilepsy, and he recipient of Best Poster Presentation certified as an EEG expert by Asian Epilepsy Academy. Our next panelist is Dr. Jayanti Mani. Dr. Jayanti Mani, MD, DNB, DM, is a consultant neurologist and epileptologist at Kokilaben Dhirubhai Ambani Hospital in Mumbai, and a consultant neurologist at Global Hospital. He is a DM Neurology from Cayman Hospital and St. G.S. Medical College of Mumbai. Epilepsy and EEG Fellowship from Cleveland Clinic, USA, 2003-2005. A special interest in complex epilepsy and EEG, epilepsy surgery. He has over 50 publications in national and international journals, and he has also written many chapters and books. He's a Joint Secretary, Saman India Epilepsy Association, Mumbai, member ILA Task Force on EEG, member of ANAESIN. Our next panelist is Dr. Arn Lakshmi Narasimhan. He's the Director and Head of Department, Institute of Neurology, Madras Medical College, Chennai. He was a winner of the Global Elsevier Atlas Award. Well done, Lakshmi. Executive Committee member of World Federation of Neurology, Liaison Officer of World Federation of Neurology, Public Relations Committee of World Federation of Neurology, 3 terms executive member in the IAN, CME convener IAN, member of Cochrane Editorial Board Epilepsy Group, advisory board member, BAOG Neurology, and past assistant editor, Annals of Indian Academy of Neurology. Our next member is Dr. Shudi Kumar. He is the head of Department Neurology at Pune Hospital and Research Center, Pune, member of the Bharani Society, fellow of the Royal College of Physicians, member trustee of Forum for Indian Neurology Education, or FINE, invited speaker on vertigo, headache and epilepsy. He's first in Pune in the SSC and pre-degree exam. He was a gold medalist in several subjects in MBBS. He's the best outgoing student of BJ Medical College, 1980. He has quite a number of publications in vertigo and neurology. The next panelist is Dr. Shudi Kumar. He's a consultant neurologist at Apollo Hospital, Hyderabad, former lecturer and consultant neurologist at Christian Medical College Hospital. He's one of the youngest to qualify as neurologist at the age of 28. His area of expertise includes stroke, neurocritical care, epilepsy, neuropathic pain, dementia, and migraine. He is also an expert in Botox administration. He has over 120 published research papers in peer-reviewed national and international journals, and several multiple book chapters he has published, monographs, and he worked as head of clinical operation Maya Clinical. Is a California-based research organization for several years. He's been on the editorial board of Neurology India, Indian Journal of Critical Care Medicine, International Journal on Neurology and Neurosurgery. He's a peer reviewer of several international and national journals. So welcome the esteemed members of the panel. So we all have listened to this very informative lecture of Professor Martin Brodie. I will ask the questions. I will start with Lakshmi. Have you used Brivaracetam as monotherapy in your practice? So far, which are the patient groups you have used in, and what is your finding, observation?
So, thank you, Dr. Taposh. So far I have used Brivaracetam as an add-on, and my usage of Brivaracetam as a monotherapy is very less. But nevertheless, a few cases which I have used it as a monotherapy, the cases are which were having very high psychiatric side effects of levetiracetam. I have switched over to Brivaracetam. I found it pretty useful. I really do not know, even though the mechanism of action of both are the same, probably the affinity for the AMPA or what, there must be some difference which would, which makes the group of patients who are fairly well controlled with levetiracetam, but they become very bad-tempered, and a switch over to brivaracetam has distinctly helped them. This is a subgroup where I've used it as a monotherapy. Most of the patients I've used it only as an add-on.
Are they all focal seizure with secondary generalization, or did you use it on primary generalized seizure like in JME?
No, I have most of these patients were partial onset seizures with secondary generalization.
Right. So I'll ask Jayanti Mani to address the same question.
Thank you, Dr. Tapas. Am I audible?
Yes.
Yeah, so I have started increasing the repertoire of patients I'm using it. Initially, I too was a little more cautious and would switch people who had behavior issues on levetiracetam to brivaracetam. And I must say, in a couple of them, they didn't tolerate it, and I had to go back as well because they felt extremely sleepy when I switched. So these were patients who had brain tumors and who had been operated. So, it could be the primary condition itself. But one striking example that I recently recollect is someone with a brain glioma who had been operated and subsequently also received radiotherapy, but in general remained quite drowsy and kept having focal seizures. So we had to use steroids to keep those seizures under control. And then what happened, he developed a urinary infection and came back, again was having focal status. He was already on levetiracetam. And because there were so many other comorbidities, I didn't have a great choice. So I said, let me just try intravenous brivaracetam and switch it from levetiracetam. And I was quite skeptical, but I said, since I don't have and he's in the hospital, let me try. And lo and behold, it made a dramatic difference that within 24 hours, those little jerky movements did improve. At least the obvious focal seizures did stop, and the sensorium also improved to a certain extent. We could argue that it was the urinary tract infection coming under control, but it has helped, and we have not had to go back to the ICU to address seizures again. So I think it at least solves some part of the problem. And I have also
monotherapy. It was monotherapy on revenge.
No, it was a second drug. He was already on one main drug, and this was the add-on drug. But we were already on 2 drugs, and I didn't want to add a third drug because he was, as it is, so ill. So instead of adding a third drug, I said, let me switch the levetiracetam. I think the first drug was lacosamide. That's what he was taking as the first drug.
Monotherapy. Have you used brivaracetam as monotherapy?
Yes, but in patients who have had genetic generalized epilepsies and who are well controlled, I have switched them from levetiracetam to brivaracetam, and they have stayed well. So I am now feeling more encouraged to start using it early on even as a first-line drug for genetic generalized. I've probably done that in a couple of patients who have come to me with early in their course of epilepsy.
Any of the other panelists, they want to sort of address this question of brivaracetam monotherapy?
Sir, I totally agree with Madam. Actually, most of those patients who were on monotherapy with levetiracetam, starting monotherapy with levetiracetam and then developing behavior issues, and then switched over to brivaracetam purely because of behavior issues, they had done very well, and hardly any patient had to be switched back to levetiracetam. So
the efficacy, you didn't find any worsening of efficacy?
No, there was no worsening of efficacy, whether it is in an emergency scenario or even in OPD scenarios. From chronic epilepsy also, if somebody we start with levetiracetam and next week they come that the child is having aggressiveness or behavior irritability, and you just switch over to brivaracetam, it's a monotherapy. So technically speaking, it may not be something like which is very well advised as first line or as monotherapy, but just because patient was reasonably controlled with levetiracetam and only because of side effects we were not able to give. So switching over helped a lot.
Right. I'll ask the question to Dr. Sudhir Kothari. If you want to switch from levetiracetam to brivaracetam, would you take a quick switch, overnight switch, or would you go for a sort of transition, gradually tapering off one drug and gradually increasing the other?
I think there are people who do both, but I would straight away switch. And in the patients where I have switched, it has usually been direct switch because I just do 10:1 roughly. And I have not had any problems with that. Since they are essentially the same mechanism, so just as we switch from carbamazepine to oxcarbamazepine using that rough percentage, 50% more, I think I at least go by that. There are some people, there is a school of thought that if the patients are well controlled, then you switch straight away. If they're not that well controlled, then maybe you can switch, you can scale it. So you could do that.
I think that's the message, really. If the patient is well controlled, you won't have a problem. If they're not well controlled, you have to be careful.
Yes, because if the patient is already not well controlled, you've got to be a little more careful.
You've got to be lucky.
His seizure might worsen. He might land up in status or something sudden.
I mean, I'll ask this question to Professor Brodie. What do you think overall the efficacy of levetiracetam vis-a-vis brivaracetam when we switch from levetiracetam to brivaracetam? Professor Brodie, would you like to?
I think if you switch due to tolerability issues, you have no problems. If that mechanism isn't doing the trick, then it's unlikely that the same mechanism with another drug is going to be beneficial. So it's the tolerability side that is definitely better. I don't think anybody disagrees. And the people who have switched successfully, if you're able to go from a drug that's not doing the job to one that is without having to titrate, that's a pretty big bonus. But everybody has to have their own feel for it and have their own experience. I showed you cases where we had 3 drugs and before we got to Brivaracetam and it worked. So I think there is a message there is you have to think about the pharmacology of what you're doing. And mostly nowadays neurologists do that. When I started, you didn't, or we didn't. Now we know about the pharmacology, and now we can say, yes, but this, if the drug is not working, and you've got another drug that works the same way, I think you'd have to be pretty lucky for it to work. So we would go on to something, as I did, go on to another drug, and then maybe at some point you come back and think, well, we're not doing well. Let's try again. The one thing about both drugs is they're so easy, so much easier to use. They're very easy drugs to use, and that is a benefit. For me, it's not, because I never get asked to talk about Brivaracetam. This is the first time, because you guys don't need to know about it, because you use it and because it does what it's supposed to do. You don't have perampanel problems and all sorts of things. So.
Another thing, brivaracetam, the maximum dose that is being used is 200 milligram per day. But suppose we say 1/10 of the dose of levetiracetam we use in brivaracetam. Now, if somebody is using 3 grams of levetiracetam per day, when we switch on to brivaracetam, what will be our dose? We don't have a 150 milligram twice a day problem.
For 200 milligrams. It's not equivalent. I mean, there's no doubt about that, because, most of, in the patients I showed you, most of the patients were on 1,000 milligrams, were on 100 milligrams of brivaracetam in my audit. And that's the reason for doing an audit, is so that you see how the drug works and what it does and what it doesn't do, and then you can explain it. So, that's equivalent, I think, to at least 3,000 milligrams of levetiracetam. It's not equivalent to, it's not 300 versus 3,000. I'm sure it's about 200 versus 3,000. But that's what you get when you look at your numbers, and that's why I always say to my young doctors, look at what you're doing. And nowadays you can publish most things. There's lots of, and it's very good for young doctors to to think in those terms and to do the little bit of literature search that they do. And then at the end of the day, I mean, the paper that I showed you, it's only 100 patients. Often I have more, but you know, in 100 patients, you get a nice paper for a junior doctor. I wasn't the first doctor.
Right. I'll ask the question to Dr. Shudi Kumar. Have you used in pediatric age group, Brivaracetam in pediatric age group? And what is your observation?
I think I don't see much in pediatric patients, so I have no personal experience.
Right. Then in elderly age group, have you used Brivaracetam? What dose you will start?
Elderly I have used. So I think because elderly patients, somehow they are the ones who tend to have more behavioral side effects with levetiracetam. So I have come across few patients who responded well to levetiracetam in terms of efficacy, but they had behavioral side effects. So I started a dose of 50 milligrams twice daily, because they were taking 500 mg of levetiracetam twice daily. So 1:10 ratio. And with that dose, they are well controlled. And so out of 4 or 5 patients, 2 of them were on monotherapy. I think earlier initially you asked this question also about monotherapy. So I think, and Dr. Lakshmi Narasimhan also mentioned that those patients who had behavioral side effects, that is a subgroup he would prefer to switch from Lev to Briv. And then they are the ones on monotherapy. And so 2 of the elderly patients on 50 mg twice daily, they are doing well. So my feeling is that they may not require the higher dose of 100 mg twice daily. So 50 mg twice daily, at the most 75. And then with that dose, they tolerate well. And the side effects Dr. Jayanti mentioned about drowsiness and sleepiness is not seen at a dose of 50 mg twice daily.
Suppose it's not a switch, it is just de novo starting Brivaracetam. In an elderly, would you like to start with 25 milligram twice daily or straight away start with 50 milligram twice daily?
I think that's a good question, sir. So I think my patient numbers are not too many to give any recommendation. I think anybody senior or somebody else you can answer that.
This was exactly what I wanted to ask, that in elderly epilepsy, most of the patients that I've seen respond to very small doses of anticonvulsants. So lacosamide, say 50 milligrams twice a day, or levetiracetam 500 milligrams total per day. So they are responding to very small doses. And if I do give an elderly person brivaracetam, I would prefer to give 25 milligrams twice a day to begin with. If he gets seizures on that, then I would go to 50 milligrams BD. I would not give 50 milligrams BD to start with, because elderly respond to really small doses for all the anticonvulsants.
So with the permission of the chair, I would like Professor Martin Brodie to address, sir, this low doses response to elderly, and in general, the Indians generally get a seizure control on a far doses far below than what is being in the Western. Any comments on that, sir?
Yeah, I mean, you're quite right. 25 milligrams twice daily is perfectly okay. There has been, particularly in the US like the view, the higher the dose, the better. I mean, the higher the dose, the more money they make. But they do go for high doses. In Europe, it's a little similar, not quite as much. And I think people now are realizing, with the sort of studies that we've done over the years and the ones I've published, the doses that you get the seizure-free patients on are really quite modest. If they don't control, then you have to push the doses, and then you start getting a few patients and you need bigger doses. But the patients that I showed you that were seizure-free after the first, well, we had 50% who eventually were seizure-free in monotherapy. Most of them were on a low dose. And that's what I always actually learned coming to your part of the world, because you guys were always using low doses. And I thought pharmacologically it made sense. But it wasn't what Americans did. And the Americans we all followed in those days. Now less so, I think. So what you're all saying is exactly what I'm thinking, what I'm doing. So any of us, if we're working on the same population of patients with the same medications, the same investigations, why should we come to different conclusions? We shouldn't. Now,
Any of the panelists, what is the experience of intravenous Brivaracetam in status epilepticus? Anybody has any observation or experience on it?
So recently I tried in about 2 patients. So advantage was that you can give a bit faster. Even people have tried giving bolus also. And it was not exactly status, but then something like an ongoing seizure. And when it was being given, the seizure, whether it was a naturally subsided or it was just a immediate kind of bolus kind of effect. So, but at least there was no adverse reaction to the injection, and patient had no seizure further. In another patient, it was given like status only, and by giving 200 milligram loading dose, patient tolerated it very well, and there was no seizure. So, just 2 patients I have tried.
I had tried in a post-operative patient who had recently had a excision of a tumor with continuous focal seizures. I tried that, and it works. And in fact, a lot of literature also supports that, especially in the glial tumors, where the response to Brivaracetam or Brivaracetam is definitely better, and Brivaracetam is superior because the cell receptor density, the SV2 is get expressed in the glial cells, especially even in tumors. I was really surprised to read about that. Thank you.
Mm-hmm. Right. I mean, they express in glial cells, but it's the neuronal cells which give seizures. So I guess you have found a good result of intravenous. All right. Jayanti, do you have you experience?
I just mentioned that one patient who was having continuous focal status and did very well. So, I mean, as I said, I was quite pleasantly, good about it. So that one was one patient where I've tried it.
I mean, there's a literature which says that those patients who did not respond to levetiracetam in status, they may also get effective response.
Yes.
Exactly. So this patient of mine was already on levetiracetam, and then I switched abruptly. So I loaded with the brivaracetam and then took off the levetiracetam almost simultaneously and switched to brivaracetam. And subsequently, the gentleman didn't have any seizures. So, and it was quite a sustained effect after that. As I said, I didn't have to go back to the ICU to solve their seizure problem. So
what dose did you administer?
Similar to what, 200 milligrams loading dose. And then because the gentleman was on 1500 milligrams of levetiracetam. So I thought I should be giving him slightly higher doses. So I did load, though he was on levetiracetam, I loaded 200 milligrams.
It would have been interesting to see what would have happened if the levetiracetam dose had been increased, and to see whether it would have made a difference.
Yeah, that's true. Absolutely.
Because people, I don't think you can equivocate the doses in that setting to oral dosing. I think you have to use more, and the patients are not going to complain. So usually we say, well, you don't treat the seizures, you treat the patients. But here is a situation where you treat the seizures. And,
so this gentleman was on a maintenance dose of levetiracetam before he came into the ICU. And these ICU doctors, as far as using levetiracetam, they don't even call the neurologist. They always give an additional 2 grams or whatever, and then they call the neurologist. So that had already been done a day earlier. And since it was not responding, that's how got called in again. So that had been tried, if that is any kind of idea that it had been attempted.
It's nice to think when you're doing it that you have a reason for it, and that's what I'm always saying. So the reason here is you're under treating, so you've got to push the dose to a higher, and if that theory is right, then you get the control rather than we'll try it and see. So, and I'm sure that's the case. I used to do, many years ago, I published a review in the Lancet on status in 2000, and I never published another paper on status again, because you know what's going to happen. Everybody phones you every time, every day, every night, because you're the expert on status. So never be an expert on status is my motto.
Since Dr. Brodie, since status every minute is important, if somebody has been given a bolus of levetiracetam and didn't respond to it, would you still persist with brivaracetam and or go on to something different now? Because you've already tried levetiracetam, and do you want to risk losing time? Because same mechanism using another.
This is exactly what I did, and it worked. So
I know it worked. It worked, Jayanti. But would you like to do it in every status when when your houseman in the ICU has already given 2 grams of levetiracetam and he's not responded? Next time, would you still give?
I was thinking of valproate or Ficompa or Eptoin, but this gentleman was in sepsis, has so many other things going. I was worried if I give him valproate, whether it will affect his liver function and get him more drowsy. So it seemed safe because we have heard and it was available. I was very skeptical. I'm always a very slow adopter of new things. But the next day, the evening I call after a couple of hours and they tell me, oh, there's nothing happening again. I was, almost not willing to believe that, but it was true. So that's why I'm sharing it here and it's very fresh in my mind.
I think he was being undertreated before. That's now that you know that he responded, you can theorize that he was being undertreated. And so you gave him more. And because it was easier to do that than to risk the side effects. And you're right. I mean, if it didn't work, it didn't work. But no harm could come to him. Whereas if you go somewhere else, you might. So I think you're on a loser to nothing here in that setting. If you think they're undertreated, then you say, let's assume they're undertreated and do either with levetiracetam or with brivaracetam. And for brivaracetam, you're getting a big bang for your bucks, really, because you're talking about 200 milligrams versus 3 grams. That's the equivalent amount.
The cost is not less because it's 200 milligrams. It still costs as much as 1,000 milligrams of levetiracetam in India. So, it's for the patient, it's not really cheaper. Yeah. But if it works, I don't think one is worried if they are equivalent.
No, I think cost is very important. This is why brivaracetam now can be a success in India, because otherwise, when I use it, it doesn't cost my patients anything, so I don't know no issues, and the family doesn't pay. So if you're taking a chance and somebody's paying for it, it's not the same. Whereas now they're not paying any difference, so why not? And there's a theory, there's a reason why you're doing it. And not just as a guess, And then once you've done it a few times, you then know the answer to questions when people say, when do you use it? You then know because you've tried it, and sometimes it's worked, sometimes it's not. And then when you come and talk to people, you know at least what your experience is. And that's what I always say. I don't tell you what to do, I tell you what I do.
I have one question, if I can ask. When Prathapas allows.
Sure.
From the pharmacological perspective, in terms of drug interactions, I wanted to know what Dr. Brodie thought about brivaracetam versus levetiracetam, especially when you're using it with other drugs like valproate and carbamazepine, because this is metabolized in the liver to a greater extent. So, are we more concerned about drug interactions when we are administering brivaracetam versus levetiracetam?
I don't think there is any. To be honest, I was just looking at this when I started to do the presentation, and there really isn't much in the way of evidence that there's any major interactions
because I did notice carbamazepine epoxide levels go up, and whether the person can feel more toxic or get a little dizzy.
Interesting. I was just looking at a paper and it said that with brivaracetam and carbamazepine you get better efficacy than with other combinations. So I don't quite know whether that's what you're saying or whether that's that's something else. But it does look as if the combination of brivaracetam and carbamazepine is a good one. So, but it's really not it's really not an issue. Side interactions, nor with levetiracetam.
Yes, I mean, of course, with levetiracetam, we use it so freely. The physicians use it, the surgeons use it very comfortably. So whether it'll be the same story with brivaracetam or we need to be a little more careful is what I was wondering.
It doesn't seem to be so. It seems to be perfectly well tolerated. And, as I say, we're talking pretty low doses. Top dose of, 200 milligrams, so pretty low doses. But, that's not to say that you don't see something that makes you think, but it's certainly nothing in the literature, and I wouldn't expect it.
Can I have liver dysfunction, you reduce the dose of brivaracetam to sort of make it half. What is the kind of cutoff? What kind of liver damage you want to reduce the dose of?
Well, they come to you with numbers, from the liver function test, and then you have to come up with an answer. And I tend to, if there's no problem, I tend not to worry too much. Adjust it down. They don't like you not to adjust it, so you always adjust it down. If the gastroenterologists are worried, then you take it down a little bit, and then if it's a problem, you take it back up again. But there really isn't. It's not metabolized. There's a number of routes of metabolism. Once you've got just one route of metabolism, there's a concern, because if you have a problem with that route, then you can have big doses, big concentration changes. But if you've got 3 or 4 possible ways in which the drug is metabolized, then if you damage one, you don't damage them all. The biggest issue is the renal situation, where, if the drug is excreted completely unchanged, then you have to be careful. But with the liver, there's usually leeway for that. And we're talking about, if we're having a concern, we're talking about patients in renal and liver failure. We're not talking about patients with abnormal liver function tests. Everybody has abnormal liver function tests. We're talking about people with real good going liver disease. And I'm not aware of a problem. But, if somebody else says, I saw a case, then I listen and I think, well, I'll be careful next time. I haven't seen a case.
Now, in pregnancy, have anybody observed teratogenicity of brivaracetam so far?
Well, it's too early, because the drug's only used as add-on. And when you're using it as add-on, you don't know whether it's the other drug, and you can't say. There's very little use as monotherapy in newly diagnosed epilepsy yet. There is some. Again, it's not been published that there's a problem, but that doesn't mean to say that there isn't. Mostly, neurologists don't like to use newish drugs in women that could become pregnant. You'll know that. And so it takes a long time before you can be sure that it's safe. I would suspect it would be from the metabolism and from the fact that over many years, over 50 years now with levetiracetam, we really don't see a problem. So why should we see a problem with brivaracetam? When the only difference really is that we've got a more potent drug, but it works in the same mechanism, but more potently. So I would guess that it wouldn't be an issue, but it depends on what the patient thinks, and I personally wouldn't worry about it. But if the patient doesn't like it, switch to something else. I mean, levetiracetam, arguably, there's nothing after more than 20 years. There's really no evidence that it's a problem.
Any of the panelists want to ask questions to Dr. Brodie?
Dr. Brodie, levetiracetam has become the go-to drug for everybody, neurologists, non-neurologists, everybody. It's the first drug which anybody uses. It's easy, it's broad spectrum, etc., etc. What do you think is going to happen in the next 5 years? Do you think brivaracetam is going to displace levetiracetam and take its place?
I think if the cost was identical, yes. But you have to start using it. And in a way, that's what I'm here to do, is to reassure you about what we know about it. And then you go away and think, well, I'll try it. And the cases you've all seen, you've said, well, and so you're starting to think, well, this is a drug I should be using more. The difference between levetiracetam and brivaracetam is not enormous, really. There's no doubt that these side effects, these behavioural side effects, are less. And so I think, so many times I get patients referred who the problems with levetiracetam haven't been identified. We have patients with learning disability whose behaviour has gone off the wall, and the doctor's prescribing levetiracetam, and that's what the problem is. We didn't know that 20 years ago, but we now know that. So if you're using a lot of levetiracetam, then you're going to say to yourself, well, if I use brivaracetam, I shouldn't see anything other than good things. So why shouldn't I try? And then you try, and then your colleagues will say, well, what do you think? And you can say, well, in the last 50 cases, we've had 40 seizure-free. And so you can only do, there's nothing in what I've said today that would discourage you from using brivaracetam more than you using that.
I have one more question. Same related to the same. Is there in India we have more than 20 or 30 companies which have come out with brivaracetam. It's pretty cheap. Is there anywhere else in the world where this experiment is going to happen, where we try out brivaracetam in de novo patients, in first time onset patients and things, which is going to happen in India, and probably we will be the ones who give the answer to, is it useful in juvenile myoclonic epilepsy, how is it useful in elderly epilepsy, etc. So is there anywhere else in the world that there are going to be so many patients on brivaracetam for the first time?
That's why the two places I do the most lecturing, 3 places. One is Brazil, one is China, and one is India, because the money is there. And it doesn't need to be huge amounts, but there's so many people that, for me to teach neurologists who are not epilepsy specialists, I want to give them a drug they can't screw up with. They can't get it wrong. And this drug is thereabouts. So all the drugs. It's like lacosamide. Lacosamide, nothing goes wrong with lacosamide. You get an occasional rash, but that's why you guys are using it. That's why I'm using it, because it's just a well-tolerated drug. But what I showed you at the beginning, there's no difference in outcome over all these years with all these drugs. If you believe that, that's the reason why people are using lacosamide and why people are using brivaracetam, because you're not going to find a difference in efficacy. So why not use the best tolerated drug? The one that doesn't cause interactions. So it's the story, really. That's why I start with the whole story from the beginning, and then we come to the latest drug, and that's what drives you into using it that way. And then you're telling me what you're finding, which just reinforces my view that why would you not use it? It's just an easy, nice, clean drug. And if it's cheap, so much the better.
Right. Anybody wants to ask a question to Dr. Brodie or want to share or comment on anything?
If nobody else, I have one more point I want to make.
Okay, sure.
I think no neurologist is going to take a chance with teratogenicity now when we know levetiracetam is so safe. So I think that is one situation which brivaracetam will never be able to overtake, because you will never have so many patients as there are on levetiracetam. So I don't think it's the end of levetiracetam. It will always be used in women who are going to get pregnant. As regards other places, maybe it might get displaced. What do you think, Dr.?
Already a lot of accidentally exposures to brivaracetam have started. Reports have started coming, and very soon there will be pregnancy registry where again the brivaracetam will run the race against levetiracetam. But at the end, I think both will have their own place, and each drug will cement their own place, and then they will have their own set of patients.
Exactly.
I think so.
I agree with Lakshmi that accidental pregnancy on brivaracetam, a lot of them will come out in future as we use more and more of this brivaracetam.
But
so we can draw observation. Yeah.
So the only other situation is if the patient's not tolerating the levetiracetam but is doing, the seizures are all right, then you can say to them, well, I want to try you on another drug that is very similar but shouldn't cause the side effects. I wouldn't have a problem making that decision, but that's up to everybody to make their own decision, depending on the patient and the setting. So I can certainly see scenarios where you can try it if the patients and the family are on side with it. I wouldn't anticipate that there will be teratogenesis, but we won't know for some time, as correctly said.
Right. If there is no other question or comment, is there any other question or comment?
Yes, sir. I mean, there are the questions from the audience.
Okay.
Can I ask you, sir? Can I ask the audience?
Sure.
I mean, can I the panelist? Yeah. Sir, just allow me 1 second, sir. So many of the question has been, you discuss on this particular platform, but there are some questions I think they might be useful. Like, one question has been asked by Dr. D.C. Jain from New Delhi. He's asking about, are there any reports of skin rashes or the allergic reaction after taking a Brivaracetam?
Not that I know of, but Dr. Brodie.
No, I'm not aware of it, but it's possible that there'll be some, but I'm not aware of it. How many levetiracetams have you seen? I bet there are not many. So I don't think, we can't say never, but I think it's unlikely to be an issue. And I certainly haven't seen a case. And if you find one, you publish it. Everybody's not agreeing with me, if you know what I mean. We're all nodding our heads saying we don't see it. So.
Yes.
What are the other questions?
Yes, sir. Sir, one more question. Dr. Naim Patel from Belgaum, Karnataka. So he's asking about the dosage modification in some of the fragile population, like renal impairment as well as the hepatic impairment. Are there any dosage modification for renal impairment as well as the hepatic impairment?
As I said,
hepatic. Yes. Sorry, sir. Please go ahead.
Doesn't seem an issue. Hepatic, I think you need to be a little bit more careful. But again, you can apply the same rules that you use for levetiracetam.
So in hepatic impairment, in renal impairment, you can use it up until the end stage renal failure. I think the dose remains unchanged. In end stage, we don't have any. We don't know. We don't use it as of now. Other questions?
Yes, one question from the Kolkata, Dr. Subhashit Chatterjee. So he's asking about what are the key advantage of Brivaracetam or levetiracetam? How we can go ahead with that particular molecule, vis-a-vis some.
That has already been, discussed by our panelists and Dr. Brodie, that the behavioral side effects is much less. They have switched from levetiracetam to Brivaracetam, particularly because of behavioral side effect. And they have observed that in majority of the cases, the behavioral problem are better.
Yeah, and maybe apart from that, severe up-titration is going to happen in the levetiracetam. It is not here in the Brivaracetam. Here, in the many attempts, you have that particular 50 milligram, 100 milligram kind of dosage. So that is also one thing. The dosage up-titration is very severe in the levetiracetam. It is not here. So yeah, yes, sir. Yes, agree with your point, sir.
Right.
Sir, I think, I can see many of the question has been discussed over here. So our panelists as well as the Brodie, sir. So over to you, sir. Yeah.
So I think it's time to wrap up. I'd like to hand over to the organizers.
Yeah. Thank you, Dr. Brodie, for your outstanding presentation. Thank you for, sir, addressing all the queries. And on behalf of Alkem, I want to extend a very hearty vote of thanks for showcasing your important work, cases, and opinion. And I would also like to thank our moderator, Dr. Tapas, sir, panelist, Dr. Lakshmi, sir, Dr. Sudhir, sir, Dr. Jayanti Mani, ma'am, Dr. Shudi Kumar, sir, Dr. Atmaram, sir, for making this program lively. And I would also like to thank you all the respected attendee doctor for taking their valuable time for this particular event. Thank you all. Stay safe. Take care.